I'm Sithembile Dlamini. I'm working for the Ministry of Health in Swaziland. My presentation will be pushing the boundaries of science and practice in a program we are calling MaxART in the country, and MaxART standing for Maximizing ART for Better Health and Zero New Infections. This will be the layout of my presentation. We'll talk about the background on Swaziland and HIV in the country, the response to HIV, the background of the MaxART program, and why it's such an exciting program for us in the country, and then basically the three arms, what we're calling the three keys of this intervention, and then the status and the next steps of the intervention. As my previous colleague has outlined, Swaziland is a small country in the southern part of Africa, a population of around 1 million people, and 76 of them living in the rural areas, and that is our geographic area in kilometers. The background of HIV in Swaziland: we have a generalized HIV epidemic with a very high prevalence in the world. Heterosexual intercourse with multiple concurrent partners remains the key driver of the epidemic, and it contributes to 94% of the new infections in the country. We also have a high TB burden, which internationally, and then HIV is a significant cause of morbidity and mortality in the country. Those are our numbers in Swaziland. The response to the pandemic: we have a national coordinating mechanism in the country, which we call NATURE, and it's the body that coordinates the multi-sectoral response of HIV. The Ministry of Health works in collaboration with other partners in the country, which includes the PEPFAR partners, the UN agencies, CHI, MSF, the AHF, and many local NGOs. We also have a very active network of people living with HIV, and our ART coverage in the country as of December 2010, as my previous colleague has mentioned, is almost at 80%. These are the numbers. The red top bar is the estimated number of people living with HIV up to 2014. And then the green bars is the number of people we've managed to enroll into ART. And if we follow that linear progression of enrollment, we expect by 2014 that we'll have that many people enrolled into ART. The background blue shade is the estimated number of people in need of ART in the country up to 2015. In Swaziland, what we are using as the current eligibility criteria is the following. We are also enrolling people with a CD4 less than 350, the WHO stage 3 or 4 conditions, and all HIV positive children under the age of 2 years are being enrolled onto treatment. As a country, we have also opted for option A, even though we're looking at of progressing towards the option B+, but again, we're looking into that for now. Services have been decentralized up to the primary healthcare level, and we have a very strong government commitment. And in spite of the challenges, government has remained committed and has continued to mention health and education as a priority. And again, in spite of the challenges, government has committed to funding and procuring our ARVs and a significant proportion of the lab consumables in the country. Then we come to the MaxART initiative. We were granted as a country 8.8 million euros by the Dutch Postcode Lottery Dream Fund for the program to run for 3 years. And it's a partnership among organizations with varied expertise. The government of Swaziland through the Ministry of Health are the ones leading it, and we have community-based organizations, people living with HIV, academic institutions, and international NGOs. With the MaxART, we decided to set an ambitious target, and that was to reach more than 90% of those who are in need of ART by 2014, and we're pushing ourselves beyond the set universal access target. And also at the same time, as much as we're pushing ourselves, we are mindful that we should also reduce the issues of loss to follow up to by under 10% by 2014. And there's also system strengthening involved, which we have to come up with innovative and effective interventions to overcome the remaining barriers for us to achieve our set goal. And the focus is on communities and facilities and the linkages between them. The program direction is for us to provide high quality, well-informed and effective HIV services to prepare the country to take treatment as prevention approach as well as to do a treatment as prevention pilot. This is a very exciting program for us. I quote Dr. Okelo, who was the ART coordinator at the time, saying that change starts with us. We have the opportunity to take on something that others have said is impossible, to show that treatment can be a form of prevention. We are going to be a model for other countries. So for us, MaxART is business unusual. We are doing what we need to do, and we're pushing ourselves further than what the set standards and goal. We have to reach the hard-to-reach groups, and at the same time not compromise on the quality of services. So the approach has to be comprehensive, and the multidisciplinary team is the ones that are delivering the service. And for us as a country, it's a unique opportunity to improve the lives of Swazis while also testing feasibility, acceptability of treatment as prevention, as it will be happening on the ground in the real world setting. So key one, these are the innovative interventions for strengthening each point in the cascade for the community mobilization part. Our goal throughout the cascade is to overcome the gaps in our system, the barriers that keep us from reaching all people in need of testing as well as treatment. So under community mobilization, we have the following activities: the community mobilization with community-based volunteers. There's engagement of traditional leaderships at community level. There's also a focus on males, where we have the male focus health days, and then adolescents initiative to increase support increase a supportive environment. Under HIV testing, we have what we call a fast track. It's a community-owned problem-solving approach to increase testing for men and adolescents. There's also strengthening of the provider-initiated testing and counseling, and then again, increased mobilization of the general other population groups. Under enrollment and care, we have the point of care CD4, so that as soon as people test, they are immediately done a CD4, which informs quick enrollment or into either pre-art or art services. And also there's the strengthening of the treatment support structure, also linkages and retention initiatives for strong referral systems. For the ART initiation, we have adopted the task shifting framework of the nurse-led ART initiation, strong adherence counseling, improved sample transport system, which reduces the turnaround time for results, strengthened supply chain systems. And then under retention and care, we have the SMS appointment reminders. We have linkages and retention being strengthened. There's improved treatment support and treatment literacy curriculums and discussions. There's linkages with community health workers and improved knowledge about experiences of people living with HIV in an effort to reduce stigma. These are some of the activities that have happened under Q1, where we demonstrate that there was a lot of community participation and involvement. An example of a male-focused health day, which normally happens twice a month in a rural setting, and we'll appreciate the difference in the generations that attend these meetings. The point of care CD4 in one of our rural clinics, as well as an adolescent support group workshop. Then we have key 3, which is the social science research and epidemiological modeling. The first part is the Positive Health, Dignity and Prevention Survey. We have a poster. It was led by the network of people living with HIV in the country, where we used them to help us understand the experiences of people living with HIV in the context of scaling up testing, care and treatment. And then the other 3 are work in progress. The second one being the human rights monitoring, where we want to ensure that country maintains an approach that protects human rights within testing and treatment scale-up. There's also a social science research, and these are the proposed topics that we want to look into. The utilization of HIV services among adolescents, the reasons for loss to follow up within care and treatment, the men's perception on HIV prevention and ART initiation, as well as adherence. And then the epidemiological and statistical modeling analysis. Currently, we want to better understand the overall ART need in the country, and then eventually we'd like to evaluate the treatment as prevention efforts in Swaziland. Then key 3 is the treatment as prevention pilot. Again, this is work in progress. The key 3 aligns with the Ministry of Health treatment as prevention framework, and the ultimate goal of this MaxART key 3 is to improve the health outcome of Swazis and to reduce new HIV infections. The goal of the pilot is to determine feasibility, acceptability, and scalability of this intervention, and also to highlight the outcome of the treatment as prevention approach. The overall approach is earlier initiation into treatment, either using a CD4 of less than 550 or a regardless of CD4. As you will see, the asterisk at the bottom, a few factors will guide and help us determine what will be the threshold at the end of it all. It will be within the government-managed health systems where we'll select sites for us to implement the pilot, and then the pilot sites will be compared with the normal standard of care that prevails at the moment. We will have to continue to focus on strengthening the entire HIV continuum of care to ensure that health and opportunities of eligible individuals are not compromised. We will have to answer the questions the nations have to provide evidence to inform future decisions and policies about HIV treatment and prevention in the country. Also, the expected global contribution, which would be an opportunity to take the learnings from clinical trials and demonstrate that it is possible and doable on the ground. Currently, what we have as an outline for the project is that we want this will be done on the ground with the goal of understanding the following. Under feasibility, we want to assess the ability of a planned package of community and facility intervention to drive the uptake of services, acceptability, how the uptake of testing and linkage and early initiation will be welcome in both at individual and at community level, and as well as the health workers, that's the clients as well as the community, and then the issues of adherence, retention, and any associated toxicities, as well as stigma. Affordability will inform scalability. So there'll be we will look at the costs per client cost, the cost effectiveness, and also to identify efficiency opportunities as we learn about what is required for treatment as prevention. The immediate and long-term outcomes is for clinical outcomes, which will include the toxicities, opportunistic infections, morbidity, and mortality, the rates of testing, treatment initiations, retention, and viral suppression. The status and the next step, we are currently implementing Key 1 and part of Key 2, finalizing the concept and protocol and budget for the pilot study, that is the Key 3, and developing partners and synergies within the country for within the country for implementation. We'll also seek approval for pilot in line with the Ministry of Health treatment as prevention framework and scientific and ethics committee. Implementation of the pilot is to start towards the end of 2012 and early 2013. We'd like to thank the Dutch Postcode Lottery and the leadership of the Ministry of Health for making the MaxART program possible. I thank you.